I'm ready.
Okay.
1 second, ma'am.
Ready?
Yes, ma'am.
Okay, so just before I start, just let our chairs, they're ready, no? Chairpersons. And Lavanya, Dr. Lavanya, are you in?
Yes, ma'am. Yes, ma'am. I'm here.
Okay, fine. Thank you. So let's go live then. Okay. So good evening, all of you. We're starting the next second academic meet of TACO. And we have a very good speaker with us, very relevant to us, because from March onwards, we are going to celebrate the Glaucoma Week. Plus, this itself is a very relevant topic. So let me invite the chairpersons and let me specifically welcome Dr. Ronnie George to this meeting, it's been a great pleasure to see you, Ronnie, and thank you so much for accepting without any hesitation immediately. So I invite Dr. Smita and Dr. Radharamanan to please come and chair the session, and the introduction will be given by Dr. Nilofer. Thank you.
Hello, good evening, everyone. Welcome to TACO's monthly academic program. I'm Dr. Nilofer, working in iVision Thrissur. I'm excited to introduce our speaker for today's session. He is Dr. Ronnie George. You all must be knowing him. He is one of the leading glaucoma specialists of our country. He is currently a Deputy Director of Glaucoma Services in the prestigious Shankara Nethralaya, Chennai. Dr. Ronnie George has completed his MBBS from St. John's, Bangalore, and he did his post-graduation from CMC, Vellore. He was awarded the gold medal for MS Ophthalmology by MGI University, and also he received the Thomas Gold Medal for Best Outgoing Postgraduate in Ophthalmology by CMC, Vellore.
You are unmuted. Muted.
Sorry. Dr. Ronnie George has published 52 papers in peer-reviewed in national and international journals. He was a clinical investigator for the population-based epidemiological studies, the Chennai Glaucoma Study, and the Chennai Glaucoma Follow-up Study. And now currently he is the Associate Investigator for Chennai Eye Disease Incidence Study. He received the Pfizer's Best Paper Award for Best Research Work presented at the 13th Annual Glaucoma Society of India meeting. He also received the Ruby Bannick Award for Best Researcher by Vision Research Foundation, Chennai. He also received the Dr. TLK Rao Endowment Award for the Best Associate Consultant of Medical Research Foundation. He is also an Associate Advisory Board member for the World Glaucoma Association and is currently the Secretary of Glaucoma Society of India. On behalf of TACO, I would like to extend a warm and hearty welcome to you, sir. Over to you now.
Thank you, Dr. Nilofer, for the kind invitation. I'd just like to clarify, I'm not the secretary of the GSI now. I think that's a slightly old CD.
Got from the SN website.
Oh, no, I think that's an archived website. It's no longer. Right?
So sorry, sir.
No problem at all. So it's a pleasure to be part of this, and I really thank Dr. Sudha for the invitation. Unfortunately, as she mentioned, this is all virtual, so I don't have the pleasure of meeting my old friends in Thrissur. So I'm going to basically talk to you about OCT, interpreting OCT from a glaucoma point of view. So any diagnostic test is basically measuring a parameter. And that measurement depends on technological factors. Can you hear me?
Yes, we can.
Yeah. So any diagnostic test basically looking at a clinical measurement. And the clinical measurement would depend on technological factors which are related to the instrumentation as well as patient factors. You also need to keep in mind that almost all our technologies compare these measurements with normals, and therefore you have normative database related issues. And all these need to be kept in mind whenever you're interpreting any diagnostic test, and the OCT is no exception. So whenever you look at an OCT, you need to look at it as a stepwise assessment. Look at the quality of the scan, look at the quantitative parameters, look at the qualitative parameters.
Ronnie, just a minute. Just
Yeah.
a minute. As somebody is put on the YouTube on, please mute it. Please mute your this thing. We're not able to hear. The YouTube thing is getting on. Hello? Please, all of you mute. Yeah, please continue, Ronnie.
So whenever you're looking at the OCT, it's always wise to do a stepwise assessment. So you assess the quality of the scan, you look at the quantitative parameters, you look at the qualitative parameters, and you compare it with the normative database and ask yourself whether the normative database is applicable and whether you could actually compare these parameters. So when you look at a printout, all the printouts are classified as green, yellow, and red, each of those parameters, or as white and gray. There are a few things that you need to remember here. Whenever you look at the RNFL analysis, it is a normative database matched to age. The ONH is matched to both age and disk area. And the green indicates that between 5 and 95% of normals had that sort of measurement. The yellow indicates that between 1 to 5% of normals had that sort of measurement. And the red indicates that less than 1% of normals had that sort of measurement. So just like in the visual field, you are basically comparing these values with a normative database of normal people. And if you see something which is very rare in normals, you assume that it is abnormal. But if you have something which is white, it basically means that you are seeing a very thick RNFL analysis value, which may be seen less commonly than in not seen in 95% of people. And similarly for the cup to disk ratio, you might have a very thick neuroretinal rim or a cup to disk ratio. Gray basically means that the database is not applicable. And in addition to areas where you don't have a disk size, which is in that range, if you have a disk area which is less than 1.3, a cup to disk ratio which is less than 0.3, or a disk or a rim area which is less than 2.5 millimeters, then you would not actually have to take this, you would have a gray mark on the printout. So when you look at a printout, never look at only the RNFL in isolation. Look at the RNFL and also look at the ganglion cell analysis. Both are relevant to the information that you're trying to gather. So when you look at a printout, just like in the visual field, you have to go stepwise. You look at the age, because that is important since the normative database is age related. You look at the quality scores, and the signal strength of at least 7 is required. Look at the actual summary parameters. Look at the RNFL map. Look at the thickness map. This is the thickness of the neuroretinal rim. Look at the deviation map of the RNFL. Look at the TISNet graph, which is again RNFL. Look at the RNFL quadrants. And each of these is compared to the normative database. And as you can see, each of them is variously colored depending on where they fall in relation to the normative database. And I'll walk you through this a little bit. So a quick look at the age, quality, RNFL map and deviation map are what you do first. And don't forget that you need to do the same thing for the GCC also. Even when you look at the ganglion cell quality thing, you look at the signal, look at the thickness map, look at the deviation map, look at the RNFL sectors which are here related to the macula, and look at the other parameters which are the summary parameters. So very similar parameters are there on both the GCC and the RNFL, and obviously there are no disk parameters on the macular cube. Sorry. So when you look at this printout on the left, you can see that everything is white. And everything is white over here because this patient is a young patient, about 15 years old, and there is no analysis for patients who are less than 18 years. And therefore, you have that, that statement here saying normative data is not available, patient less than 18 years of age. And these are what the discs look like. And why do you want to do this if you're not going to get any normative values? It is sometimes useful because you can still get some progression data from this patient, even if you don't get normative values. So we have looked at the quality of the scan, and next you want to look at the quantitative parameters. And the quality of the scan, as I mentioned, should be at least 7, and this is from the previous time domain machine, but it's the same principle. If you look at these two scans here, this is a poor quality scan, this is a good quality scan of the same patient, and you can see how all the normative values have changed. And there's this interesting paper which talks about signal strength and its impact on RNFL thickness. And here you start with a signal strength of 5 and you go until a signal strength of 10. And you can see that the RNFL thickness measured actually varies by almost 20 microns. And that can be all the difference between a normal scan and an abnormal scan. So having a good quality scan is really important in looking in assessing an optic an OCT scan. What about the qualitative parameters? Now, qualitative parameters, just like in the visual field, you look for artifacts. Here too, you look for artifacts which can be motion, blink, segmentation, or centration related. And when you look at a printout, all these need to be taken into account. So I'll give you an example of a centration related artifact, and this is on the TopCon machine. Here you can see that the disk is off center, and here it's on center. And you can see how these two printouts change dramatically. This one shows a lot of abnormal areas, and once you have centered it, it is actually a completely normal distant graph. So this is from the Zeiss machine, where you can see that this ring over here is not centered. This ring is also not centered, and you can see a bunch of abnormal parameters there. Let us repeat the scan after centration, and let's look at these two. So the one on the left is not centered, and the one on the right is centered. And what is apparent here is that if you just look at the parameters itself, you can see a lot of red in this one, which reduces here. You can see that the thickness map on the Tisnet graph looks different. You can see that the quadrants are more abnormal on the in the non-centered graph as compared to the centered graph, and the areas which are abnormal also vary. So centration is one thing that you need to look at. Is the disk well centered is the ring well centered around the disk? The next thing that you need to look at are these movement artifacts. And this is basically seen as a discontinuity in the blood vessel. What you're seeing over here is the discontinuity in the blood vessel. So the disk is centered, but there is a movement artifact, and the movement artifact can affect all your measurements because they are not accurately taken. Segmentation artifacts are the next thing that you need to work out. So the red line basically tells you this is the internal limiting membrane margin, and this red dot tells you that it is 150 microns above the Brooks membrane. So make sure that the image is in the center. If this touches the upper margin, it can cause the image to fold over and you can get a mirror image. This in the image in the middle shows you an irregular placement of a segmentation line, and as does this one on the right. So let's look at this printout now. So first, straight away, you're looking at the left eye. The signal strength is really bad, just 3. What else are we seeing? We are seeing blink artifacts which are causing loss of data in the inferior segment, which are seen by this red, the black mark on top. We are seeing a segmentation error causing loss of data. And when you look at the GCC, is similarly poorly taken. You're seeing a lot of loss of data. Those black marks indicate that nothing has been measured there. When you look at this GCC scan, you're seeing these red hot areas which are looking at very thick areas on the NFL. And this is essentially an area which has not been scanned at all. So when you repeat the scan and you repeat it well, all the red goes out and you have completely normal looking GCC scan. So the quality of scanning is really important. And don't forget over here on the image on the left with the poor scans, you had very good signal strength. It was just that there were artifacts on the scan, and that's why you were getting this mess. Next thing that you need to look at is whether it's comparative with the normative database. Is it applicable and could you compare it? So when you look at the normative database, you are basically looking at the green zone being 95% of the normals, the yellow zone over there being 1 to 5% of normals, and the red zone being less than 1% of normals. So when you look at the neuroretinal rim thickness, the solid line indicates that the neuroretinal rim follows this pattern for the optic disc. The dotted line indicates that for the left eye, and the solid line for the right eye. The RNFL thickness also follows a familiar double hump pattern that you see, with the solid line being for the right eye and the dotted line being for the left. And each of these quadrants is again shown classified based on the degree of abnormality or normality. So if you look at the image on the left, they are all normal. If you look at the image on the right, you can see that the neuroretinal rim thickness for the left eye is completely in the red, while for the right eye, you do see that it is going into the yellow and the red for the superior rim. The RNFL thickness for the left eye is again very borderline, and both superior and inferior mostly in the red. while for the right, it's mostly normal. And that shows up in the quadrant analysis and the clockwise analysis, where you can see that the left is more or less normal except for the supratemporal quadrant, while the right is, the left is showing much more abnormality than the right. So when the disc, as I had already mentioned to you, when the disc area is less than 1.3 millimeters or greater than 2.5 millimeters, you get all your volumes, all your markings grayed out. And if two eyes have a similar profile, then the symmetry parameter is close to 100%. So let's just take a look at the image on the left, where you have a RNFL symmetry of 98%. Most of the parameters similar. You look at the image in the middle, and you find the RNFL symmetry is very abnormal at only 34%. And that's because there are significant differences in the values on both sides, between the right and the left. You can see here that the disc area is actually greater than 1.3 millimeters, but this sort of disc area is outside the normative database for this age group for the machine, and therefore it grays it out. When you look at this area here, and here you're seeing that all the values are grayed out, because even the rim area and the average cup to disc ratio for this patient are completely outside the normative database. So when you have something which is grayed out, you need to interpret it with caution, because these values don't exist in the normative database, and any interpretation means that this is a disc which is not absolutely normal. So let's look at this neuroretinal rim graph here. What you're seeing is that in the yellow, in the NRR thickness, the left eye is reaching the bottom. In the RNFL thickness 2, the left eye is reaching the bottom. This cannot happen because you never have an RNFL thickness of 0, because you always have supportive tissue which will show some sort of measurement on the OCT. And this is because of an artifact, which you can see over here, is that they've really got no measurements there, and that's the reason you're getting it. And that's the reason the RNFL graph is flat in that quadrant. The same thing, you're seeing a similar thing on the right side, and here everything is grayed out because they really don't have values which they can compare with. Let's look at this image, and this is basically somebody with a superior arcuate defect, and you have an inferior RNFL defect and the RNFL map which corresponds to this. And this is a fairly good quality, it's a very good quality scan, and this is what a good quality scan should look like. And you have really no doubts in comparing what you're seeing here with what you're seeing on the field. This is the right eye of a patient, and I'm going to focus on the right eye here. And here you're seeing biarcuate defects. And when you look at the OCT scan, again, fairly good quality. The disc area is slightly outside what they find in the database, but the rest of the parameters are comparable. There is some asymmetry, and the asymmetry is more related to the rim area than the average RNFL thickness. And you're seeing on the RNFL thickness map, both superior and inferior poles show thinning. The neuroretinal rim is mostly in the red, and the Tisnet map is also just mostly in the red. So when you look at this, it does appear that both the disc and the field correspond. You do a 10-2 for this patient, and you see defects mostly superiorly with a few defects inferiorly. Compare that with the right eye, which is the leftmost image over here, and you can see that it corresponds fairly well to what you're seeing here. This line that you're seeing here is an important parameter, and this is the temporal raphe sign. So in most of medicine, you don't see sharp cutoffs like this. So when you see sharp cutoffs like this, they usually indicate some sort of pathology. And this is again because of the way the RNFL bundles are distributed. If you see this sort of a sharp cutoff, it usually means that there is something going on there. So let's just take a look at this OCT of a patient. So here you have the typical hourglass appearance, which you have in a normal eye, and here you have absolutely complete loss of the hourglass. The average RNFL is normal here, and here it is definitely showing thinning. You're seeing a focal RNFL defect here. Here you're seeing superior and inferior defects. You're seeing superior neuroretinal rim thinning just in the yellow zone over here on the NRR map. And here you're seeing inferior thinning of the neuroretinal rim in all quadrants. On the RNFL map, you're seeing a normal double hump pattern in the right eye. In the left eye, there's a loss of the double hump pattern with superior and inferior thinning. No RNFL thinning in any quadrant here, and here superior and inferior are showing thinning. And in the last quadrant-wise analysis, we are seeing focal 11 o'clock RNFL thinning, while here you're seeing thinning in most of the superior and most of the inferior quadrants. So this is basically what an asymmetric glaucoma would look like. I'll also now share with you just a few examples. And so basically this is the OCT of, and what you're seeing over here, I'm just going to try and highlight the abnormalities. One, very poor signal strength. Two, the disc area is not in that limit. In fact, just look at that disc area. It's 0.31 square millimeters. That's a tiny micro disc, and the disc has not been normally taken. Left eye, all the parameters are not comparable to the normative database. That's the reason the neuroretinal rim area is shown completely in gray. And you look at this RNFL contour tomograph, you can see that that image is reaching the top. Once it reaches the top, you're not likely to have very accurate values to compare with. So this is an image which should, an OCT which should be discarded and repeated again. So this is the GCC, and here you're seeing a poor quality scan. You are seeing something like a temporal raphe sign, but with this poor quality scan, you cannot really interpret it unless you repeat it. So here again, you have a poor quality scan. You have an unrecordable disc size, and we will look at this area in a little bit more detail in the next slide. And what you're seeing there is this portion, and you can see that there is a discontinuity in the vessel. So you're seeing a movement artifact there. You're also seeing the same thing, movement artifact in the left eye. So this is again a scan which should be repeated because of the movement artifacts, even though the left eye scan is fairly good quality, the right eye is not. So this is a GCC scan which is showing you these bizarre images over here. And this is partly because of what you're seeing here with the horizontal scan being taken too anteriorly. You're seeing this sort of an image which is completely an artifact and should be discarded again. So here again, you have a slightly poor quality scan in the right eye, and the disc areas are outside normal limits, but the rest of the data is still usable. And this is the classic temporal raphe sign, which suggests inferior loss. Okay. So this again is here, quality in the right eye is poor, left eye is okay. You're seeing disc areas which are not in the normative database. You are seeing inferior loss, reasonably well-centered scans, and you are seeing loss on bipolar loss in the left eye and mostly inferior loss in the right eye. And this does not really correspond with the previous image that I showed you. You're seeing some diffuse loss. You're really not seeing a classic temporal raphe sign, and you need to interpret the GCC with caution. Here, the other eye has poor quality scans, and again, very small disc size on one side. The other disc looks okay. And this is, again, a lot of asymmetry. Disc sizes are huge, but the scans are otherwise relatively normal. So once you have this sort of a, but except for a centration issue in the right eye. And this centration issue, you can make out is shifted to the right. And because of that, you're getting a lot of artifacts there. You look at the RNFL map and you can see that the peak is shifted to the left. The peak would normally correspond to the peak of the green area, and that is shifted here. And that's partly because of this measurement circle. You repeat it and you find that the peaks are better aligned. It's still a very large disk, so you don't have normative data, but this sort of information gets cleaned up. Okay, we will now move to this disk where again you're seeing poor quality images there, and you're seeing a lot of loss. It's more towards the macula than classically the disk, and you're seeing this on both sides. But when you look at the GCC, you are seeing a good temporal raphe sign, and you're seeing this sort of anomaly here. So this sort of anomaly is because of a retinal issue, and that's what you're seeing there. So this can be because sometimes of a floater, or it can be because here it was a localized large PED which showed up as a thicker area on the. here on the right eye, you're seeing a subtle temporal raphe sign. You're seeing just that little step there, and it's worthwhile to see whether this patient has some damage on the 10-2. So what you're seeing over here is basically not a very good quality scan. Again, disc areas are slightly outside normal limits. Looking at it at one shot, you would think that everything looks okay, but I want you to pay attention to these areas here. So you're seeing linear streaks like this. And this is again anomalous. You do not get lines like this while scanning. This is because of a movement artifact again, another type of movement artifact that you may see. So when you're looking at the OCT to diagnose glaucoma, then one of the things that you have to remember is in advanced glaucoma, it has good diagnostic capability, just like any other instrument. In moderate glaucoma, it has moderate diagnostic capability. And in early glaucoma, it has poor diagnostic capability. So you should keep this in mind and make sure that whenever you're interpreting the OCT, keep in mind that if you want to reliably pick up every glaucoma with an OCT, you have to have, on an average, 35% of ganglion cell loss before the structural test is classified as abnormal. This is a blanket rule for every glaucoma. There will be some where you'll pick it up with 5% damage, and there'll be some where you'll pick it up only with 50% damage. But just like visual fields, applying the OCT to all glaucomas and using that as the gospel truth can be problematic. In order to maximize the yield of any diagnostic test, keep in mind that if you have a disc which looks like this, which is practically normal, every test that you do will be normal, and any abnormal test is probably a false positive. If you have a disc which looks like this, then every test you do will be abnormal. And you should keep in mind that whenever you're interpreting the OCT, you need to understand the technology. It has its limitations. Do not interpret it without looking at each of the factors of artifacts and quality. And don't forget that there's a statistical basis for every test. Every abnormal test is not a disease. We should certainly mention here that there is a lot of OCT images where you have at least one which does not go in the normative database. And always look for that before you make a final decision. So do not interpret a diagnostic test in isolation. And as always, there is no substitute for a careful clinical assessment. Thank you once again for the invitation.
Thank you, Dr. Ronnie. That was a very good presentation, and I think most of us would have found it very useful. I just want to ask you, what percentage of your glaucoma practice does OCT, like how much of your OCT do you use in your glaucoma practice to make decisions?
Yeah, I mean, to be honest, I don't use the OCT as often as I would, as maybe I should or maybe I could, because one of the problems in India is that cost is a consideration. Yes. But in my early glaucomas, in my ocular hypertensives, in my disc suspects, I would definitely like some form of structural test, whether it's a disc photo or an OCT is up for grabs. A disc photo definitely if they're very young, because technology will change over time, and OCT also helps. But keep in mind that glaucoma, what we are trying to prevent is functional disability. So the visual fields cannot be taken out of the equation. OCT helps, but don't forget that visual fields are what we are relying on to keep the patient's vision preserved.
So for every patient who has a visual field defect, then only you will start treatment, even if the patient has a family history. If the OCT printout shows a defect, say there is an RNFL defect, but the field do not show, like a pre-perimetric, but say they have a family history, do you really start treatment?
Now here, this is a slightly gray area, and I will tell you how I would approach it. Now, if there's a 35-year-old person who comes to me with normal pressures on multiple measurements, with a very suspicious looking disc, OCT is slightly abnormal, maybe a family history. Now, this is a person at that age, I do not really expect him to fit into the normal tension glaucoma part of the POG spectrum. So I would hesitate to start that person on anything. On the other hand, I have somebody who's 65 years old with a similar pattern. There, if I'm suspicious enough clinically with the disc and otherwise, I might consider treating depending on that person's life expectancy and other things. So at 35, I would not. At 65, I would take a hard look. But again, the fact that neither of these cases have functional damage is what you need to remember. Glaucoma is a slow disease. You wait 3 months, you wait 6 months, you wait a year. Nothing happens on the visual field, you can still elect to watch. On the other hand, in either of these situations, if the pressures were consistently high, even in the absence of a visual field defect, I would consider treating, because these are basically ocular hypertensives who are high risk for progression as per what we saw in OATS.
Yeah, that's the point. Thank
Good
you.
evening, Ronnie. Can you hear me? Okay.
I can hear you, sir.
Yeah. What about your cases with myopia? How you use OCT?
So myopia is difficult because you are going to have an abnormal looking disc. Very often you'll have some scattered field defects which don't make any sense. And your OCT is very likely to be abnormal. So here, this is a situation where I would do all three. I would do the visual field, I would do a disc photo, I would also do an OCT. I would not use the OCT to help me with diagnosis, but I would definitely try and use it to help me with progression. Because myopes, typically, even the visual fields, you'll see some defects, you'll see something going on in the macula. If you have consistency on 2 out of the 3 instruments, then I would consider it would be helpful for me in progression. But definitely not for diagnosis, because these machines don't have anybody with more than 6 diopters of myopia in their normative database anyway. So these type of discs don't exist in the normative database.
Otherwise, how do you follow up for preperimetric glaucoma with OCT?
So one of the concerns with preperimetric glaucoma that you always have is because our intraocular pressures anyway keep fluctuating. So you see somebody with a very difficult looking disc, I would always like to get baseline measurements on all the instruments, disc photo, OCT, and visual fields. And just like in a field, you require 2 baseline photos, 2 baseline fields. On an OCT also, you require 2, preferably 3 baseline images. So over a 6-month period, I would like to get at least 2. And after that, follow them up 6 monthly or annually, depending on how suspicious I am of preperimetric disease and what the other risk factors are. So close follow-up is important. And maybe if I follow them up for 3-4 years and I don't see anything, I would even say that, yeah, probably everything is fine and we'll just reduce your follow-up to annually instead of 6 monthly.
So you mean 6 monthly is enough, because our PGs are calling them back every month.
No, definitely. Even my advanced glaucomas, we don't call back every month, and they are at real risk of progression. No, definitely not. You would not call them back monthly. You call them back after 3 months, and if both those tests are stable, then you can maybe see them 6 months later, and that should be more than enough.
You were mentioning about disc photographs, just addressing from OCTs. So how do you take those stereoscopic photographs, or do you do the usual fundus camera photographs?
So we do the usual fundus photo cameras, but it's possible to do what we call pseudo stereo photographs or non-simultaneous stereo photographs. So when you do that, you basically keep your machine, I'm not sure what you can see is, if this is the pupil, you keep the camera at closer to the left extreme of the pupil, and you take a picture of the disc. And then you slide the camera to the right extreme of the pupil, and you take a picture of the disc. So this is like looking with your left eye and with your right eye. And with both those pictures, you can, many of us can fuse the image and actually see a 3D image, or you can use a commercially available stereo viewer to actually see a 3D picture. And if I encourage everybody to learn how to do this fusing, because once you do that, you can just take a look at even a printout and fuse it and have a 3D image of the disc, and that's really useful. So the important trick is left side of pupil, right side of the pupil, slide the camera, don't tilt the camera.
Oh, I'd like to have a video or something in which you fuse, or how is it done, because that would be very beneficial. Okay. I know, I understand you're moving the camera to the left edge of pupil and to the right edge, but the fusing part.
Okay, the fusing part. Okay, let me see if I can find a resource, or I would try. So what is described is basically, now suppose I have the 2 images on the screen.
Yeah.
What is described is when you're training yourself to do it, either put your thumb out, focus on your thumb while looking at the 2 images at the back. And what you will see is you will actually see a third image in the middle because your eyes are crossed.
Okay.
then the trick is to look at the third image without quite looking at it. That's the only way of describing it. If you do this 5-6 times, but keep your thumb outstretched, look at the thumb while focusing on the back. And you can do this with any set of stereo discs. What I would suggest is initially take deep cups, because then it's much easier to appreciate it. And if you practice it a few times, you'll get it. And most of us who are myopes find it easier than non-myopes.
And you take the printouts on normal paper or on any other special? How do you?
We actually
Out or is it a slide?
no, we put it out. It's there on our electronic medical records, but we give a printout on glossy paper. We usually also give a CD to the patient.
Okay.
And I tell them that you keep this, especially for the pre-parametrics and the young people. I tell them you keep it in cyberspace, because 5 years down the line, CDs may not be around. You won't have to read it. So just keep it somewhere where you can always access it. And so I think these photos are an important and underused part of.
Thank you very much for telling us.
Your follow-up is 6 months or 1 year. Then how frequently you repeat the test, OCT or field or something? How frequently you repeat OCT and all these things?
Yeah, so if it's a pre-parametric glaucoma, I would like to get 2 investigations within the first 6 months, because I need a baseline. And if those 2 are similar and everything else is okay, I might repeat the next one a year later. If it is established disease, then I would like to get at least, I would aim for 4 to 6 tests within the first 2 years, because I want to pick up a rapid progressor. If they have established field defects, then 4 to 6 within the first 2 years. First 2 usually 3 months apart, and then the rest spread.
Drawing, Ronnie. What about disc drawing? Do you encourage that?
It's a good thing to do. LVP does a lot of disc drawing. I myself find it difficult to do. And since we have an EMR, with the mouse, it's very difficult to draw an accurate disc drawing. But yes,
I think postgraduates should learn.
Yes,
no?
yes. In fact, I also encourage my postgraduates to go sit next to the slit lamp and draw the disc and show it to me. So when you look at the disc and you draw it, then you know what all to look at. And then you go back and see, that helps. In fact, there is also a very good resource which is available online. I think I will probably get a message next week from the WGA also about it. It's called the GONE project, the GONE project.
Yeah, GONE project, glaucoma.
Yeah, the glaucoma optic nerve. It's really worth doing. I mean, all your trainees should do it, because it's a systematic way of looking at this, and they tell you how you have done in relation to everybody else. And so it's an important, the only downside to it is that you don't have stereoscopic images. So you're looking at monoscopic disc photos, but still the principles of disc assessment are done very well.
Yeah, I did that GONE project thing, and then I realized that how bad I was in examining the disc.
And so there is another project which is currently going on. I mean, that's not open source. So one of the issues that you have is, as glaucoma specialists, we don't always agree on what is glaucoma. What's a glaucoma disc? So there is a project going on which has about 300 glaucoma specialists globally who are looking at a certain set of images that include the disc field and OCT, and saying what is glaucoma and how sure are you that this is glaucoma or this is not glaucoma? And from that, they hope to come up with some sort of a consensus on what you call glaucoma. So maybe by next year or sometime later this year, they will come out with something.
Any more questions?
Ronnie, do you have a different strategy for a large disc or a small disc OCTs or interpretation? I mean,
so whenever I have a large disc, there are 2 things you have to look at. We are all taught that large discs will have large cups, and that is true. So careful look at the neuroretinal rim is important. If the large disc still falls within the OCT normative database, then you can interpret it just like you would otherwise. If the large disc does not fall in the normative database, then take a look at the RMFL. But keep in mind that circle, the measurement circle, should not be too far away from the disc. because the circle is a fixed proportion of the disc size. So sometimes it will be much further away from the disc, and therefore you will have slightly thinner RNFL under that measurement circle. So look at the pattern, look for localized damage. For small discs, obviously, if they are smaller than the OCT normative database, then it becomes a little difficult. But again, focus more on the NFL than the disc parameters.
Okay, thank you. Any other questions?
We have a case report, sir.
Okay.
Dr. Lavanya. Ronnie, please stay on.
Yes, yes, yes.
Hello.
Lavanya, please share your screen.
Am I audible? Hello.
Yes, yes.
Yeah, from the first slide.
Yeah. Yes. Yes, my dear colleagues. I'm Dr. Lavanya from iVision Eye Hospital, Trichy. Today, I'm with advanced glaucoma in one eye. Actually, this was to be done by Dr. Manjunath, but due to some unavoidable emergency, he could not be here. So I'm doing it on his behalf. So, coming to the case. A 42-year-old lady who's an IT professional. She came few routine eye checkup as she was using, she had a refractive error, but she was not using the glasses regularly. She did not have any systemic and there's no and she
Lavanya, I think your this thing is not good.
While she works on the computer for a long period of time.
Avnia, you switch off the video. Then you can switch off the video. Switch off the video. Mute. Then you present.
Is it okay now?
Yeah,
Okay.
Okay, shall I continue from the same? Hello?
Yeah, Lavanya. Hello. Please proceed.
The intraocular pressure. Yeah. Hello, am I audible?
Yes, yes.
Yeah. And the intraocular pressure by applying in the right eye was 40 of mercury and 8 in both eyes. This is this photo of the right eye, which shows a 0.9 cupping with narrow retinal rim. There is a loss of gross loss of RNFL, and the superior vessels, they are a bit tortuous. This it's to identify targets and the rest normal.
I am actually a little sorry. I couldn't hear much.
Hello.
Hello.
Hello,
Lavanya,
ma'am. I think some, yeah.
yeah, there was some problem with your. Can you?
Is it okay now?
Yeah, it is okay now. Yeah.
Yeah.
No, no, no. Still getting.
Okay now. Should I start from here or? No,
Yeah, you can start with the slides, but your talk is not clear.
Okay.
Yeah.
Was this visible? Like. This was okay. I think I'm coming to the end of the presentation. On prostaglandin analogs and alpha-2 agonists. And in mind, we sent her for a systemic evaluation and a neuro evaluation was also advised for evaluation of a headache. Now,
Okay, Lavanya, could you stop sharing that?
Suppose the left eye going to get involved and how we are going to follow this patient, how we are going to investigate. Yes, ma'am.
So Ara sir, could you catch that?
No. Can you hear me?
Yes, sir.
Okay. I am also losing the connection here, but I think this only thing I understood is unilateral glaucoma, no? 40-year-old.
Yeah, 42-year-old lady.
42. Okay.
Yeah, with advanced glaucoma in one eye and the other eye is normal.
Could it be a CRVU, Nilofer? I mean, lot of tortuosity of that vessel. No, sorry, not Nilofer, Lavanya.
Yeah. There were no other features, ma'am. Like she didn't have any sudden, or she didn't come with any symptoms. Actually, she just walked in for a routine examination, and actually, this patient I had not seen. It is Manjunath's patient, but since what we discussed, that's it.
Dr. Ronnie, any comments on that?
Yeah, I lost connection between, so I missed a bit of it. But sometimes what helps is to take a very close look at the angle. Especially she's relatively young, so you might sometimes see a more juvenile looking angle in one eye than the other eye. And that could indicate that that eye actually started having high pressures before the other eye. So if you see a dissimilarity in the angle, that can sometimes explain this. But given that one eye behave like this, you need to also carefully rule out any secondary cause. And that could
Actually, yeah, in older age, I have seen many people having this unilateral feature. Is it common like that?
Yes, POIG can very often present unilaterally, but you have to rule out a secondary cause. There may be some occult pseudoexfoliation, a vague history of trauma. So careful examination, and only then, we say, okay, this is a unilateral POIG. The other thing that, I'm sure gonioscopy has been done well. The other possibility is if you have angle closure, because that can be asymmetric, and a careful gonioscopy with the lights off can sometimes help you out.
No, and what I mean, and Lavanya, what about the pressures? I didn't catch that actually.
Yeah, IOP was 42 in the right and 18 in the left, and the correction factor was -1 and -3. She has a little slightly higher myopic power in the right compared to the left.
What about
-2
like something like Osner-Schlossman or something? Can it occur in this kind of? Yes.
If she's absolutely asymptomatic,
yeah,
that's unlikely. Usually they will be symptomatic. You will see some inflammation. But comparing the pigment in the angle in both the eyes helps. And see, 46 is very often more likely to be associated either with a gross angle pathology in terms of, a juvenile onset, or with a secondary glaucoma. 46 with POIG does happen, but is uncommon.
What treatment are you, what are you doing with the patient now?
Actually, she came just a few days back, so we just worked up, did the workup, and we have started on prostaglandin analogs and alpha-2 agonists. We have sent her for a systemic evaluation, and she's to come back.
Can I ask why you didn't consider a beta blocker?
Yeah, beta blockers.
No, I'm just asking whether, because I didn't get the whole presentation, so I just want to know whether there's any reason why you did not consider a beta blocker. In addition,
actually, it's not her case, so she is not really. Dr. Manjunath is not here to tell us about it.
Yeah.
One question. What about the OCT finding? Did you do an OCT?
She showed its ECC analysis.
I didn't catch it. What is it?
I should share this. Share it once again.
It was a uniform loss or something.
Did Dr. Ronnie see that?
Yeah.
Sir, can you comment upon it?
I saw it in bits and pieces. It came and went.
Can I say a few words actually, ma'am?
Yeah, say
Okay.
please.
Yeah, actually, I have seen this patient first. Actually, what happened was it was Sunday duty, and she was my last patient. So actually, she came. She was like an IT professional. She just had foreign body sensation, and then in the EMR, I saw the NCT. It was like in the 40s. I'm like looking at her. She's like totally comfortable. Her only complaint was like foreign body sensation, and she had like migraine and all. She said just like so. I thought computer problems, computer vision syndrome. Then while examining again, and IOP was in the 40s only. And then the disc I saw, it was like, zero point 0.8 cupping and all. Then I referred to Manjunath.
Anything about the feels? What does the feel like?
Actually, after that, I didn't see the patient. I gave to refer to Manjunath sir. So the first initial when I saw, that's what I said. And the investigations were done the next day. I just started her on Diamox and then call her back the next day because that day we couldn't do HF and it was Sunday. The investigations could not be done. So that was like how I saw the patient first. So I just wanted to give you a picture of that.
But I feel there is some element of vascular occlusion also there.
Superiorly, some hemorrhage. We could see some red areas, hemorrhages.
Unfortunately, we didn't catch it properly.
Nilufar, since you have seen the patient first, any history suspicious of any uveitis or any idocyclitis to suggest secondary glaucoma?
Complained about like headache, migraine, she said. And then she had like slightly, I remember like a minus power in the right eye. So after that, I discussed with Manjunath sir. So he said like this is asymmetric and there is it could be maybe the headache could be due to this high IOP and all that. Because she's
any treatment with migraine drugs, anti-migraine drugs?
No. Sometimes she just takes paracetamol. That's it.
Only that.
They were staying in Bangalore. They just came for few days, and then when I told about the investigation and we need to work up, so then they stayed back for a couple of days.
Unilateral glaucoma in a 42 age may be either secondary or maybe undetected developmental or congenital. Maybe that's.
Sudha, you were suspecting CRVO.
Yeah.
But thing is, CRVO, we expect neovascular glaucoma, no? So that definitely the eye should be more inflamed.
No, I'm not really completely sure. I was just asking. So I was thinking of something like an NTG. Was it happening there? Some occlusion in that area? If you can do a cardiac evaluation for that side.
That way. Achha, you are thinking in terms of NTG.
So can it be worsening because of some amount of ischemia also in that side?
But then it's 46. No, pressures are very high.
Yeah,
so
I didn't catch that. I didn't catch that. But that is also the possibility is that a CRVO has been induced by a secondary. I mean, the open angle glaucoma has induced it because there is definitely some tortuosity there.
So it may be worthwhile to do biometry on this patient since there's a difference in the refraction. You might actually find that if there is a difference in axial length between both the eyes, then a careful look at the gonio once again might make sense. Because if you have a slightly loose lens, which is intermittently closing, otherwise pressures of 46 and she's comfortable, which suggests a gradual increase and not a sudden rise in the pressure. So this has been going on for a while, obviously with the disc looking the way it is.
No, I still feel you should carefully look for any keratic precipitates. I don't know in a female, but Posner-Schlossman does proceed very silently. And then suddenly it goes into severe high risk pressures and then patient very rapidly loses vision. I have had 1 or 2 cases like that.
You know, actually, I agree. I mean, it is either a secondary or there is a developmental. And if it's a secondary, we have to rule out every secondary cause.
Dr. Rani, you were saying the lens is moves in people with a bigger axial length?
No. What I was saying is sometimes if you do a biometry, you'll find slight asymmetry in the anterior chamber depth or the lens thickness.
Okay.
Aerophakia.
Yes, and that might indicate you have a slightly bulky lens in one eye compared to the other. So therefore the angle may be a little bit more compromised. Or there may be some subtle history of trauma. If you carefully take another look at the angle, you may actually see a little bit of recession or a little bit more difficulty in indenting it open. do it with the room lights closed and see whether this could, because we've sometimes seen asymmetric angle closure like this.
Okay. Yeah.
And you do the refraction, you realize that one eye is actually shorter than the other, and that's the reason for it.
Okay, that was a nice distinct topic, but unfortunately, the network didn't help. So I think if everybody's questions are over, I'd like to thank Dr. Radha Ramanan sir and Dr. Smita for joining us today and chairing this session. And over to Dr. Sujata for the final vote of thanks.
Vote of thanks, sir.
Sujata, you're muted. Still muted.
Okay, can you hear me?
Yes, yes.
Okay. Good evening, ladies and gentlemen. It's a great pleasure for me today to offer a vote of thanks. In the name of the Thrissur Academic Club of Ophthalmology and on my personal behalf, I thank Dr. Ronnie George, eminent faculty, Shankar Netralaya, Chennai, for his excellent presentation. It's a tricky topic in interpretation of OCT in glaucoma for every one of us, and we all have benefited from your talk, sir. Now I thank senior faculty Dr. Radha Ramanan and Dr. Smita for chairing the session and actively contributing to the discussion. I also thank Dr. Lavanya Pramod and Dr. Manjunath, Eye Vision Hospitals, Thrissur, for their case presentation. And now I thank all other senior faculty and other TACO members who have attended the session and made it a memorable event. I thank KSOS and Dr. Rajesh Sukumaran for sharing the Zoom platform for our monthly meeting. I also thank Dr. Bastin and Dr. Tanu for their technical support. I once again thank each and every one of you. Thank you all. Good night.
Thank you.
Thank you.